I'm just going to add another case with some imaging examples to further highlight some of the mechanical characteristics of this device, and then we have a little bit of time for discussion, hopefully. So I'm going to show a case of a patient that I treated a few years ago. He's a 72-year-old salesman who walks a lot as part of his job. He's got diabetes, hypertension, dyslipidemia, and coronary disease. He's had Rutherford 3 claudication on both sides, and we actually had treated his left leg first, and we had a mild amount of PTSD from that experience because he had a similar calcified SFA to what you just saw in Brian's case, moderate to severe calcification, and the right side was a mirror image. And so, I'm sorry, we treated the right first, which was a mirror image disease, and it required a lot of treatment, as you just saw, orbital atherectomy, angioplasty, and overlapping stents. So here's his left-sided angiogram. You can see he's, in the subtracted images, you can't appreciate the calcium, but you can appreciate with the ruler that this is a long segment of disease, really from the ostium all the way down to the adductor hiatus. You can see better in the next shot where the reconstitution is right here. You know, there's a heavy amount of calcium in this vessel. And I'll show you the runoff. He's got, fortunately, good runoff below the knee. So in these cases, you know, at the time, we were trying a lot of different kinds of tools to cross lesions. I have subsequently regressed, if you will, to wire catheter strategies as default. But this is an old device called the Wildcat. And we were able to cross this lesion and confirm that we were intraluminal. And this is something we can talk about from a technique standpoint, Brian, but I like to pre-dilate with an undersized balloon first to establish a channel, and then subsequently do aggressive pre-dilatation with a balloon that's about 0.5 millimeters greater than the size of the Supera that I'm going to deploy. In a lesion like this, I think that there's excellent data for using Supera, and so this is why I would choose this. So this is a 4x200 balloon. You can see that it profiles relatively well when we inflate it, and then subsequently we came back in with a 6x100 and dilated it up to what we thought was an appropriate size. And you can see the balloon angioplasty result is not dissimilar to what you'd expect. It's sort of like a bomb has gone off and you have vasovisora collaterals to the veins and extensive dissection. So even with prolonged balloon inflation, and for example, in a situation like this where you might consider using drug-coated balloons, I don't think that you're going to get an adequate result. So we tried further focal force balloon dilatation in those few areas where we felt like we didn't have an adequate result. And then because we were interested at the time in OCT, we were doing imaging. And here you can see as I pull back the catheter over 75 millimeters, this is, considering all the calcium we started with, a pretty good demonstration of how well we were able to prep the lesion, but we've got extensive dissection along the length. And despite the flow artifact, you can see that we've been able to prep the lesion pretty well. Our reference vessel diameter by OCT was 5.6. So just, I'll play that again just for good measure. You can see, especially down in the more distal part where we have good images, we've got nice expansion, and then shortly you'll see the dissection planes. You can see already subintimal hematoma here, and I think I broke it. Yeah, here. All of this is subintimal hematoma and dissection. So we did such a good job at lesion prep that we've now got flow-limiting dissection. So this is when we thought that Supera was the appropriate treatment, and you can see the deployment. I would warn those that are not familiar with the deployment delivery system that the wire will come back as you are ratcheting forward the device, and that's something that requires a little bit of forethought. You can see here when there's heavy calcium, despite our aggressive lesion prep, we tend to stack, which means you can see this sort of more densely packed area of Supera below and a little bit more so above. And then here, because we didn't have a appropriate Supera in size and diameter, we put a standard nitinol stent, which was actually a common practice until recently. And so then, just for fun, we went back after post-dilatation and did repeat imaging. And here's what Supera looks like on OCT. Just like on IVUS, it's perfectly circular, right? It's totally round, and you can see the interwoven nitinol braids with this sort of characteristic appearance. It's almost sort of mesmerizing. And then you can see the overlap with the standard nitinol stent, which looks quite different in terms of its OCT appearance with the characteristic shadows. And here, notice that the stent is no longer circular. It is a D shape, and that was exactly where we saw that heavy calcium just above that area. And you can see again, as you come up, you have nice expansion, but still not a perfectly circular result, consistent with the principles that Brian delineated in his talk. So here's what the final angio looks like. There's a bit of a dissection up top, which we did treat with a drug-coated balloon, but the Supera gives you a beautiful, almost bypass-like result, as Brian alluded to. And we have what looks angiographically to be a nice result on angio with the standard nitinol stent up top. But in fact, you saw what the intravascular imaging looked like, and that you had some deformities in the patient. This patient now is free from clinically driven TLR for almost 4 years and has been doing well. So, to complete the conversation, I think when I talk about stents and their failure modes, restenosis is the most vexing problem that we deal with. And sort of characteristic of just about every intervention is a length to restenosis relationship. The longer the lesion, the greater the risk of restenosis. And there's only one device that I found that sort of defies that dogma, and that's been the Supera stent. Shown here on this slide are 1-year primary patency from a series of studies. These are all peer-reviewed publications, and what you see is that as you go from shorter to longer lesion lengths, and these studies from Don Jacobs, for example, in St. Louis, and the Super Sub study, we're talking about 30 centimeters of stent in many cases. And you're looking at 1-year primary patency, not TLR, which is a clinical endpoint, but an objective Doppler endpoint of between, at the lowest, 79%, and at the highest, 94%. So 80 to 90% primary patency at 1 year. And as you saw from the Superb register, from the Superb pivotal trial, there's relatively little drop-off, only a delta of about 7% in clinical endpoints from years 1 to 3. So this is sort of a paradigm shattering technology that I think everybody needs to understand how to use as we now come full circle in the era of drug delivery with balloons alone and realize that scaffolds may be something that we need to supplement our drug delivery therapy. Thanks very much. These are our obligatory safety profiles and disclosures. Thanks for your attention.